Okay, I think we can start. Good afternoon, everyone. And welcome to one of the last sessions of this conference. And it's aptly titled, When Donors Leave. I think many people have already left the conference. I think the organizers were quite ambitious in getting us this large venue, but thank you for those that have stayed in this auditorium. My name is Yogan Pillay. I'm from the Department of Health in South Africa, and my co-chair is Therese Ndri-Yeoman from Cote d'Ivoire. I will kick us off. This session is basically try and understand issues around sustainability of especially resources, funding, and how countries are likely to cope if and when donors leave. And we all know that development assistance is not in perpetuity, that it comes and it goes, changes over time. What is funded is also not immutable. So we would like to hear from our presenters, and I will now hand over to my co-chair to introduce the first presenter. Therese?
Thank you very much. I'm pleased to present the first speaker, Naomi Lins de Roche. She speaks about when donor funding leaves, the immediate impact of resource of USAID's withdrawal of support for direct HIV care and treatment at a public health facility in South Africa. You have 10 minutes for your presentation.
Thank you. Thanks for the opportunity to speak today. I'll jump in if I can advance. Okay, the HIV epidemic in South Africa and the South African government's response to the epidemic has evolved over time. Since 2004, the South African government has funded the vast majority of its HIV/AIDS response, however, and this is significantly different from other countries with PEPFAR support. PEPFAR funding in South Africa began in 2003 and continues to the present. From 2003 to 2014, PEPFAR-funded organizations called Implementing Partners were responsible for directly delivering HIV care and treatment via comprehensive care management and treatment facilities, or CCMTs for short. This direct service delivery by PEPFAR's Implementing Partners via the CCMT model was phased out over a period of time between 2013 and 2014. And today, South Africa's public health facilities provide HIV care and treatment much as they would any other public health service in their clinics. In some cases, PEPFAR-funded partners continue to provide assistance, but it's in a supporting role. So in the maps here, you can see the city of Johannesburg and its administrative regions. You can also see on the right a highlight of one of those regions of the city. The red dot was the location of a CCMT. It was a container made into a clinic, basically located in the parking lot of a government-funded primary health clinic. You can also see two clinics nearby in the region. When the CCMT was operational, all three of the public health clinics would have referred patients who were in need of antiretroviral treatment to the container, the CCMT site. In this particular study, we aimed to explore the impact of integrating the HIV treatment services into the day-to-day operations of the primary health clinics, those three clinics. And we focused specifically on changes in human resources, staff workload, and financing. We essentially conducted a natural experiment. We looked retrospectively at budgets and expenditure data, clinical staffing data as well, patient loads and services rendered. And we looked at while the CCMT was operational and then after that. Data were collected from a number of sources within the country and reviewed visually in Excel, and then we conducted an interrupted time series analysis in Stata. In this kind of analysis, which is rather simple, an outcome variable is looked at over multiple time periods before and after introduction of an intervention or policy to look for differences in trends. So here's a bit of a story, the story of ART provision in South Africa and at these three clinics, in a sense. On the left, you see that the CCMT opened on the grounds of Clinic 1 in 2007. In 2009, the implementing partner placed a nurse affiliated with the CCMT at Clinic 2, and that nurse was offering ART services there. At Clinic 1, I should have mentioned, the CCMT would have been offering the ART services, and the public health staff at the clinic, at Clinic 1, would refer their patients in need of ART to the CCMT. At Clinic 3, there was never a CCMT staff person permanently based, but a roving doctor was responsible for training nurses on initiating and managing ARV treatment. And in fact, Clinic 3 started offering ART to its patients with its own nursing staff in 2011. So the pink box that sort of spans a number of years on the timeline, in fact, represents this introduction and scale-up of nurse-led ART provision in South Africa. This was happening not just in this region, but throughout the country. The CCMT started downsizing and handing over the responsibility for ART treatment and service provision to Clinic 1 staff in 2012. The staff based at Clinic 2 left in 2013, and the CCMT was then fully discontinued in 2014. And I just want to say that while this was happening in this particular region, in fact, lots was happening in South Africa with regard to HIV care and treatment. And the one thing that I'd like to highlight is that guideline changes occurred, making more people eligible for ART, and we did see increased numbers throughout the country. So here we see some of the results of the interrupted time series analysis. This is patient headcount data. Headcounts are all patients seen for all services at the clinics. As a reminder, with this kind of analysis, we're looking at trends and changes in those trends across different periods. So we have 3 different periods for comparison here. The time when the CCMT was operational at clinic, on the grounds of Clinic 1, the time when the CCMT was phasing out, closing down, and the time after it was completely gone. So looking at the headcounts at all 3 clinics, we see there was an increase in headcounts during the CCMT's operational phase, and as the CCMT was closing out, a slight decline or stabilizing of the headcount numbers. In Clinic 3, in fact, you can see a steeper decline that would be on my far right in the period post-CCMT, and this was due to a time of clinic renovations when they were not seeing patients. And also just another important point on this slide, though we did see a decrease or a stabilizing of trends post-closure at all 3 clinics, the level after CCMT closed, the number of people seen was still higher than the number of people seen before the CCMT opened at all sites. Okay, so here we see staffing and the annual number of patients seen expressed as staff workload at all 3 clinics. In the table, you see the staff complement, the number of staff working there throughout the year for both the CCMT and the public health clinic, and the bold row at the top is those numbers combined. At Clinic 1, as expected, we saw, comparing the period when the CCMT was operational to when it closed, we saw a halving of staff, clinically trained and staff at the clinic. And in terms of workload at that site, we saw that the number of patients seen per clinical staff member per year more than doubled, from just under 2,000 patients to about 4,600. At Clinic 2, the number of staff remained relatively stable. They lost that nurse, but then they hired, and in fact, they hired more staff eventually. And workload did increase there initially, but with the hiring of new staff, returned to kind of stable pre-CCMT levels. And at Clinic 3, staffing was relatively stable over time, as was the workload, though we did see that drop again in the final year of observation because of those clinic renovations. Here we see the number of ART visits at each clinic over time. These results are also expected. At Clinic 1, there was an increase in ART service provision throughout the time when the CCMT was operational, and then a decline as the CCMT was closing and patients were able to be managed at other clinics in the region. And so then we see at Clinics 2 and 3 that they start offering ART services, and those numbers increase over time. On this slide, we see overall laboratory expenditure. This is from South Africa's National Health Laboratory Service. This is all lab expenditure, not just HIV-related expenditure, but it does seem to us that this data are largely driven by the costs of monitoring HIV-positive individuals. The trends here are largely the same as for the ART visit slides. They look very much the same, though you can see for Clinic 1, the decrease in terms of the decrease at Clinic 1 happens prior to the closure of the CCMT, likely due to changes in guidelines related to lab-based monitoring in the country. On this slide, we're looking at real per capita expenditure by the region on behalf of the 3 clinics. So a small or primary healthcare clinics in South Africa do not manage their own budgets and spending on a day-to-day basis. That's offered at kind of one administrative level higher. This data reflects staff wage bills, training costs, printing stationery, so really the day-to-day operational expenses. It does not include medications, so the ARVs or the lab testing data that we just saw. And that's important because those are big expenses when it comes to managing HIV in South Africa. Those things are budgeted for separately in the country. But just focusing on this, the day-to-day running costs at the clinic, you can see there was fluctuation over time. The pink is again the period of CCMT closure. But those fluctuations don't seem to be impacted much by the closure of the CCMT. And in the last bullet on the slide, you can see that we also, in our analysis, looked at provision of other primary healthcare services. We looked at immunization of children under age 1. We looked at family planning and chronic disease management services. All of those also varied over time, but not in such a way as to suggest that the closure of the CCMT and the intake of the ART services had an impact. So in summary, there were several moving pieces during our period of observation, and that's a limitation. Our results are limited to the data available. But keeping those limitations in mind, we observed that integration of HIV treatment into the public health clinics resulted in mostly expected impacts. The clinics did respond differently to integration of the ART services. Perhaps some were better prepared for the transition than others. But we did not see, in fact, it seems for the most part that integration of HIV treatment into these public clinics did not result in reductions in terms of the delivery of other primary healthcare services, which I think is important. And to conclude, the new global 90-90-90 targets will require a redoubling of testing and treatment efforts in South Africa and elsewhere. And going forward, we would advise that monitoring of staff workloads and looking at service quality, something that we were not able to look at in this analysis, would be important for sustaining South Africa's successes and achieving similar results in other settings. Thank you.
Any question? Yes?
Okay, thank you. Jorge Saavedra is Healthcare Foundation Mexico. And as we know, because that's the title of the seminar, when donors withdraw, they sometimes look for the sustainability, and not just bilaterals, but also multilaterals. But usually the concept of sustainability is just to sustain. That means that to maintain, but not to keep increasing on the same rate. And it's something that you are showing there. That's like clear evidence that is not sustainable if the concept of sustainability is different from the current one. Like if you think sustainability should be the same slope of the increase of new ART, that's not happening after the donors leave. That's my interpretation.
Well, I think it's important to remember that first, the period of observation is it's just a matter of a few years. But then this particular cluster of clinics represents one site where there was PEPFAR support and quite high patient numbers, and then other clinics which were responsible for absorbing those patients over time. And so we did see an increase at the other clinics, and this is just 3 of many clinics in South Africa. So during this same time period, other clinics that did not have CCMTs went from providing no services to providing services. So I would caution you from drawing that conclusion from just these 3 clinics. I think that in fact we did see an increase in treatment provision nationally.
No, I think the point is well taken, that we need to think about sustainability in more than one way, including ramping up, especially with the 90-90-90. And we can see that in South Africa as well, I'm sure in most countries. So we'll have to think about it in the way in which you articulated it as well.
Any question? Thank you, Naomi. I would remind that Naomi Lins-de-Roche is a senior researcher in health economics at the Health Economics and Epidemiology Research Office. The second speaker is Jessica McGillen. Jessica is a research associate in the HIV Modeling Consortium at Imperial College London. She will speak about how changes in United States funding policies could impact the HIV epidemic in sub-Saharan Africa.
Thank you very much. It's really a pleasure to be here and to get to be part of this session. Yes, that's right. I'll be talking today about how changes in US funding policies could impact the HIV epidemic in sub-Saharan Africa. And this is a modeling study that we at Imperial College London have carried out with collaborators from AMFAR and Friends of the Global Fight. Within the broader landscape of health and development expenditures, the US is the largest donor to the global HIV response by virtue of PEPFAR and contributions to the Global Fund. But there has been a large question mark over this role in the past few months because the US Office for Budget Management and the Budget has proposed a budget blueprint for fiscal year of 2018 that cuts foreign aid funding and also states an intention to maintain current numbers of people on treatment with PEPFAR, but says nothing about expanding treatment to newly infected people or continuing to scale up prevention interventions. So Congress is due to vote on this budget in September, and there's been a lot of public discussion around the proposed budget and what role the US should take in international health funding going forward. But we have felt that the conversation was missing answers to 2 key questions that we thought were important pieces of evidence for informing this debate and the choices around what the budget will be in 2018 and in the future beyond that. These 2 questions are, first, can we characterize a historical counterfactual? So what impact might US investment have had historically on the epidemic in sub-Saharan Africa? And secondly, looking into the future, what might be the impact of the US changing its investment strategy? So the analysis we used for this study was based on a paper that we published last year, and it lays out a compartmental model of HIV transmission structured by risk group at subnational resolution across sub-Saharan Africa. So we have a model for each of 203 subnational regions at administrative level 1, so usually provinces, in 18 countries. And each of these models is calibrated to available local data on HIV prevalence, demographics, key populations, and historical scale-up of treatment. And then, so together these models cover 18 countries, which captures 80% of the HIV burden by people living with HIV across sub-Saharan Africa. And for this study, we then extrapolate those results to obtain figures for the entire subcontinent. Under a limited funding envelope that varies depending on the scenarios we're considering, we explore what kind of treatment and prevention allocation might be possible and what kind of impact would arise from that. This is all generally a financially based study, so we estimate what amounts of funding could be available under different scenarios. And our financial data comes from multiple sources depending on the source of the funding. So our PEPFAR data comes from the Office of the US Global AIDS Coordinator. We have global fund disbursements, both from the US and other donors, from AidSpan, domestic public spending data from UNAIDS, and other international donor data from national aid spending assessments. So first considering the question about the historical counterfactual to try to characterize what impact the US investment might have had historically on the sub-Saharan African epidemic. We estimated the financial losses that could have occurred in the overall AIDS response had the US never founded PEPFAR, and then also if, in the absence of US influence, the Global Fund had never gotten started. And so we took a much smaller amount of money available overall for treatment scale-up. And in addition, we supposed that without US influence, the price of ART might have remained higher at more like the levels that were seen around 2001 or 2002 prior to the beginning of the Global Fund and PEPFAR. And so we do this in order to characterize a kind of worst-case counterfactual scenario. And so we don't assume any kind of fungibility in that we assumed that domestic sources would not have compensated for a kind of lack of US funding and influence. And this is in order to be kind of characterize as comprehensive as possible a historical counterfactual of no US investment in the AIDS response after 2002. And we see in the figure, this is along the y-axis is percentage of people living with HIV who are virally suppressed. And we see that with much less money in the absence of US funding and with higher ART costs, we would only have been able to achieve a very small scale-up of treatment across the continent relative to what actually did happen. So looking at what the impact of this would have been, we see in both for historical new HIV infections each year on the left and historical AIDS deaths on the right, the number of new infections and number of AIDS deaths would have been much higher each year without PEPFAR and the Global Fund, relative to what actually did happen historically. And in total, this would have been roughly 4 million more HIV infections by the end of last year, and about 5 million more AIDS deaths by the end of last year than what we actually saw. And the increase in new infections that happens in this historical counterfactual case occurs because with such little ART scale-up, we're not preventing further new infections. So turning now to question 2 and asking what might be the impact going forward of changing the US investment strategy. We thought that 3 factors would drive the achievable impact of treatment and prevention in the future. First, funding contributed by the US and other international donors. Secondly, domestic financing contributed by implementing countries themselves. And thirdly, policies determining how all of those resources get spent. So we developed a series of modeling scenarios to explore these different drivers of achievable future impact. So looking again at percentage of people living with HIV successfully virally suppressed, but now looking into the future over a 15-year period, the black curve on the bottom is no further program expansion, and this is what we think is not unlikely given signals from the US about only maintaining current numbers of people on ART in the future, as well as recent evidence on stagnating or potentially declining donor funding and competing priorities experienced by implementing countries. But this is again kind of a worst case, no more limited future US involvement type of scenario. And we see that while we're maintaining the same number of people on ART as has currently been achieved, overall the percentage of people living with HIV who are virally suppressed would actually go down going into the future because because more new people are getting infected with HIV and not being put onto ART. Then as we move up from blue to green to yellow, we're increasing the optimism of our future scenarios. So if we suppose that instead of drawing back its involvement in the AIDS response, the US were instead to modestly increase its financial contribution, we would be able to see a much more ART scale-up going into the future. And then if on top of that, domestic governments were to increase their own spending to meet more ambitious spending targets, then we would get more scale-up still. And I've noted on this graph that we would achieve 90-90-90 by 2020, given our modeling assumptions, with increased US funding and also ambitious domestic scale-up. Then finally, if we take the same amount of money as in the green curve, but we allocate it more efficiently, taking into account the information we have on subnational epidemic dynamics, to allocate funding to the most cost-effective prevention interventions and people and places across sub-Saharan Africa, then we can get a bit more impact still and actually do better than 90-90-90 given our modeling assumptions. Looking at the impact this has on new infections each year, we see that with no further program expansion, we would be getting quite a pronounced increase in new infections because we wouldn't be getting enough people onto ART and preventing new infections, and so incidence would be continuing to increase. And as we move up in optimism in the scenarios, we get more and more impact, with the most impact coming from increased US and domestic financing, as well as optimization of how those funds are allocated. And a similar pattern is seen with future AIDS deaths each year, where with no further program expansion, we would sort of halt the decline, or at least slow down the decline in reduction in deaths that we've been seeing. And then again, the biggest reduction in deaths, of course, comes from a situation where we have the most money and are doing the best things with it. So just to summarize in a way that allows us to compare directly to the UNAIDS fast track goal, on the y-axis is percent reduction from what was seen in 2010 over this 15-year period we consider from the end of this year through 2032. And under no further program expansion, again, we have actually an increase relative to 2010 levels of new infections that we're seeing. And as we increase the amount of funding and also allocate optimally, we can get very close to the UNAIDS fast track goal. And the specific numbers here depend a bit on our modeling assumptions and our specific projections for how much money we think will be available. But we get very close to the fast track goal with multiple sources increasing their funding and also using resources more efficiently. And a similar pattern is seen in deaths, again, where we get the closest to the UNAIDS fast track goal given our assumptions with increased US funding, ambitious domestic funding, and optimal allocation. So to conclude, we estimate from our historical counterfactual that the US investment in the sub-Saharan HIV response may have saved nearly 5 million lives. And if the strategy proposed by the US in their budget blueprint is adopted and then also more widely adopted by other donors, we could lose the opportunity to save a further 2 million lives over the next 15 years. And instead, we find that modest increases in donor and domestic funding and improved allocation can achieve the UNAIDS fast-track goals. And of course, we don't know how other countries might have acted in the absence of US involvement, or what they might choose to do in the future, or what their response might be to changes in US policy. But we've tried to cover a fairly comprehensive consideration of what might happen in the worst case and explore what could be done better and how good we might be able to do. And we hope that this will provide one of many pieces of evidence and kind of a synthesis of available evidence in a formal way that might help people make these choices of US funding policies in future. So I'd just like to acknowledge my colleagues at Imperial College London and collaborators at Friends of the Global Fight and AMFAR. And thank you very much.
Thank you very much, Jessica.
Ready?
We from
Ben Ryan from Pause Magazine in the United States. Thanks for this important analysis. I really appreciate it. I wondered if you could take off your dispassionate scientist hat, the statistician hat, and put on your concerned citizen hat, thinking about ethics and morals. Let's pretend Congress was sitting in here, and then I was Donald Trump. What would you say? It's the hair. In all seriousness, what would you say to them as they confront making these important decisions?
Well, I would say that the aim of this particular analysis was to bypass political language and the political conversation and try to provide the dispassionate scientific assessment.
Right, of course.
But I think it's pretty strongly in favor of continuing funding and continuing to scale up both treatment of newly infected people and prevention of new infections. And we really stand to lose a lot of recent progress if we don't continue. And the amounts of money that we're talking about in this analysis, at least, are small percentages of the total U.S. federal budget. And I think we can fairly easily and very effectively ensure that we continue this progress.
Good evening. My name is Christine Ortiz. I work for a USAID CDC implementer out of Washington, D.C. And I do realize that your dispassionate scientific hat was focusing on lives and people being able to get viral suppression. However, I was wondering whether you had thought of teaming up with maybe some health economists or health financing specialists to actually cost this out as to the money we have saved, the economic growth that there has been in Africa because of the U.S. involvement in the past decade, and what it might cost in the future. I think that might be a much more persuasive argument to the people who can ultimately make that decision.
That's a really good point. Yeah, so yes, for this analysis, we were concerned just with the epidemiology and impact possible, given the amounts of funding we think might be available. But yeah, I would be really interested in the future to connect this to larger health economics and beyond, and look at poverty reduction and a lot of the wider economic effects of this kind of intervention. And I think one thing that maybe this type of analysis makes very clear is that prevention is really important for future financial efficiency, because if we only focus on treatment, then the financial burden of treating everybody is going to be enormous. And so with prevention, we can take down the longer term costs of this whole response. But yeah, I'd be interested in doing a formal study of that, to follow on from this.
Yeah, David Barstow, a very worried American citizen. So thank you very much for doing this analysis. This is really important. And I would like to see it graphed in the same way the fast track model did, because that made it so clear what the alternatives were. And you've now presented what's a third scenario. You know, we had the fast track scenario, the constant scenario. You've given us one that is the sort of the one we never hoped we'd have to think about.
Right.
And so to present it in that form, I think would be really, really very helpful. And with a comment about the economics, there was someone from South Africa who talked about just about the cost of increased ARTs for the non-prevented infections is, one piece of that economics.
Great. Yeah, thank you very much.
Thank you. Oui.
Hello, my name is...
Mrs. Oui, yes. You.
Me? Yes. Great. I love being chosen. My name is Jennifer Wesson, and I'm with InterHealth International. Thank you for this analysis. It's devastating, obviously. One question that I had, if I understood correctly, there was the line for increasing U.S. support, and then there was a line for increased also domestic support. And they seem to be parallel. So what was the assumption that you made about, I don't know whether to look at the screen or at you, what was the assumption that you made about domestic spending? Because, excuse me, as economies improve, I would assume that domestic spending would increase and that you would see sort of a higher slope than just U.S. funding. So I'd just love to hear what your thinking was there.
Yeah, I can go back to it actually. The green curve, the blue curve, the assumption there was that domestic governments would increase their HIV funding only in line with economic growth. So we used projections from the IMF about economic growth and then calculated from that with other data sources how much of that is going to HIV specifically. And then we assumed that out past the IMF projections that the rate of economic growth would be constant over the remainder of our intervention period. And so this is so the blue scenario is if domestic countries didn't ambitiously increase their funding to meet any spending targets, but just allowed it to grow in line with economic growth. And then in the top green scenario, we said if domestic countries instead did increase their spending to meet these, so we used a target proportional to the HIV share of overall disease burden in each country. And I think you're seeing. Oh, sorry. So you're seeing the lines leveling out, I think, because we allow the money to be fungible over time, and so it gets spent right towards the beginning of the scenarios, and so you see a dramatic increase in the short term, and then it kind of levels off over the long term. It's just the way the money ends up spent in our model. But I could maybe explain more afterwards if that hasn't answered it.
You?
If I may just please get a suggestion regarding the underlying model assumptions. I work in Uganda, and Uganda has a history of preventive strategies that actually allowed us to see a decline even as PEPFAR kicked in. And I wonder if in the assumptions that you projected, might it be helpful to imagine a scenario where the behavior of individuals, in addition to national spending, really return to the prevention approaches, which is like ABC, for example. It may not outweigh the impact of unprevented infections, but I just thought it might also make the assumptions a little more realistic, perhaps, and maybe convincing to someone like President Trump and others in Congress who may not be as sympathetic to worst-case scenarios, but yes, still compelling.
Yes. Yes, that would be good. I think so. In this study, we assumed that in the absence of the U.S. funding, any behavior change programs that had started prior to the founding of Global Fund and PEPFAR would have continued, and any that started after, we assumed were at least partly funded or influenced by the U.S. And so we only allowed half of the behavior change that historically occurred in the cases where it was happening after the time of PEPFAR.
Please make your question short. Yes.
It is very short. Nadia Samagudu from the Institute of Human Virology, Nigeria. What I really want to know is what are the 18 countries that were included in this analysis, because your graphs could look very different depending on what countries you analyzed. And number two, the real question I want to ask is Nigeria in this model?
Yes, it is. The 18 countries, they were selected to represent a variety of sizes and burden levels of the epidemic. And so we wanted to capture a wide range of sort of types of epidemic, generalized versus concentrated, and size of country, and economic level. And so and then, of course, subject to data availability. So it was sort of a compromise between trying to get, to capture as much of the burden as we could while staying computationally tractable. So that's how we selected the countries. You could find, I suppose I won't list them all here, but you can find the list in the paper that I referenced at the beginning, because it's at the bottom here. That's the same countries.
Yes.
Maybe this is in the paper as well, but I just wanted to know what the price tag is, or how you defined a modest or small investment in percentage and dollars.
Well, I can't actually. The paper on this study is under review at the moment, so I can't give specific numbers, but we assumed, I think I can say we assumed a 10% increase on current funding levels from the US, and that was our kind of modest funding increase.
The last question.
Gesine Meyer-Rath from the Health Economics and Epidemiology Research Office in South Africa. I wanted to just ask a question, but now I also have to add a comment. So as a health economist, I know adding cost into this model will probably not lead to cost savings, even if you add in productivity and the reduced need for AIT, and that's just based on all the analysis that we've done in the past. So in the end, I think sometimes we just have to decide that we are putting in this money in order to save lives and be happy with that. But be this as it may, I'm very happy to contribute if you want to add cost, of course. My question is just very quickly on your counterfactual in the graph that you showed that was tracking infections. It seemed as if the counterfactual was actually tracking your worst case scenario until 2006. This might need a slightly longer explanation than you have time for, but could you, if it's quick, could you just tell us quickly why?
You mean this one?
I can't see the slide, sorry.
Oh, sorry. Tracking. I think, do you mean that the counterfactual case took a while to start really increasing?
No, it seems there was a reduction in infections in the counterfactual as well as in the worst case until 2006.
Yes.
Oh yes, that was because we did still allow some behavior change and a little bit of ART scale up, and then so some of the behavior change that was really shaping the epidemic in the early 2000s was still allowed to continue, and then going kind of from 2005-ish onward, the larger effect was coming from having gotten so few people onto ART.
Thank you very much, Jessica, for your
advocacy. Thank you very much.
I call the third speaker, Vinette Pabrou. Vinette Pabrou lead ERV market intelligence for the HIV access program at CHE and serves as CHE's liaison to the ARV procurement working group, EPWG. He speaks about estimating the size of the pediatric ERV markets in 27 low and middle income countries through 2025 at PMTC initiative continue to succeed. Thank you.
Sorry, that is a mouthful, the title. No conflicts of interest to declare. So the context for all of this work is that we face a paradox when it comes to addressing pediatric HIV. On the one hand, we want to end pediatric HIV. On the other hand, we want to ensure that the best ARV formulations are available for children. And so effectively, what we're doing is we're aiming to shrink the size of the pediatric ARV market, while at the same time asking manufacturers to invest in development and commercialization of some of these newer formulations that are not yet on the market. And so as we have these discussions and try to understand what the best approach is to make these products a reality, and actually get to the point where these drugs are in the hands and mouths of children, not just approved from a regulatory body, we really need to have a reasonable directional sense of how this population is going to evolve, and in order to be able to understand what the future need for some of these new formulations might be, in particular in terms of patient numbers that might need these formulations, and therefore what the commercial considerations might be. But first, some quick context. To begin with, the ARV market is small, much smaller than the adult market. There are far fewer children living with HIV, thankfully, than with adults, but there are far fewer than that even on ART to begin with. And while these data are slightly dated, the trends are basically the same. And the most important aspect to the pediatric market, which is already not necessarily the most commercially attractive for suppliers and manufacturers, is that unlike the adult market, there has been a significant decrease in the number of new infections as PMTCT initiatives have continued, and that's a good thing. And at the same time, we've got children who age out, and they grow into adolescence and into adulthood, and no longer need the same formulations that they may have started their treatment on. Compare that with adults, where if the patient can tolerate the drug and they don't experience viral failure, they can be on that same formulation for several years and live a healthy and productive life. And at the same time, we have some fairly ambitious global targets to reduce the number of children living with HIV even further. And the point here is, even if you believe that these targets may not be met exactly on schedule, the point is the commitment behind these efforts will have an important effect on this population. And as we start to try to estimate what the need for some of these formulations might be, there are several challenges. And the biggest challenge by far is the lack of credible data. It's very hard to get reasonable, reliable age and weight breakdowns within countries, the line of therapy within the regimen breakdowns, the formulation breakdowns in countries. That can be very challenging to have a good handle on in terms of the kind of record keeping that exists today. And so trying to use some of those patterns of uptake of the formulations in use today is hard as an approach for forecasting how new formulations might be taken up and what that demand might look like. Whereas with the adult market, that may be a little bit more straightforward. But we do have some trends that we can look at the global level. Again, these data are slightly dated. The most recent UNAIDS data suggests that there are slightly more children living with HIV than previously thought. But the point is the trends are basically the same in that the number of children has been declining, the number of new infections has been declining, and the number of AIDS-related deaths have been declining. And what that means is, as you start thinking about the size of the population, as the new infections and AIDS-related deaths decrease and they sort of offset each other, what's going to be a bigger factor in determining how quickly this market declines is going to be the aging out into adolescence and adulthood. And the good thing is, with age, we can kind of have a handle on, in that we know that a child age 0 today will be age 1 next year and age 2 the year after, and so on and so forth. And so if we have a starting set of numbers, we can try to model out and track those cohorts. We can add a mortality factor to these cohorts. We can add a new infections component to this. And while both trends are decreasing, and we can debate exactly how much they're going to decrease over time and are those trends going to continue at the same rate or not, the one constant is going to be that aging out, in that every year a child age 14, if they survive into the next year, will turn age 15 and presumably no longer need some of these pediatric formulations, and they can start using the adult formulations. And so we were lucky enough to receive some provisional age breakdowns by country for 27 countries from UNAIDS, thanks to Mary Mahi. And I do want to emphasize that these are provisional estimates, and there are limitations to the accuracy of these data, particularly at the country level. But we hope that in aggregate across the 27 countries, the totals by age are more or less in the right ballpark. And then these 27 countries represent 77% of the total global pediatric HIV burden, and 85% specifically within low and middle income countries. So some of the assumptions that we used based on the data that we received in 2015, there were about 64,000 children in the age 0 cohort. We modeled 3 scenarios in terms of new infections as they relate to some of the the 3 freeze target, specifically the start free target. The aggressive scenario assumes that these targets are met on time, i.e. there are 20,000 or less newer infections every year. A moderate scenario where these targets are met 2 years late, that is to say by 2022. And a status quo scenario where the decline continues more or less in the same trajectory that it has been over the last few years. And in that status quo scenario, we assume conservatively an 8% decline, just to be slightly more conservative than the 4-year average negative 14% we had seen, and the 10% decline we had seen between 2014 and 2015 at the global level, as reported by UNAIDS. In terms of mortality, we assume these 27 countries accounted for a similar proportion as they do for the number of children living with HIV, that is to say 77%. And in terms of a pediatric mortality drop over time, which we assume may be attributed to increasing ART coverage, and we have seen this decline pattern already, we kept a similar decline pattern as we've seen so far at 8%. And this leads to the implied patterns that you see over here in terms of mortality and new infections. The 3 scenarios for new infections, the dotted blue line is the aggressive scenario. So you see by 2022, the new infections drop down to 20,000 per year, and we keep that flat for the rest of the period. The purple dotted line being the moderate scenario, reaching in 2022. And then the status quo scenario, which is also declining, but never quite reaches that level within the time window that we have here. Just 2 quick notes. For simplicity, in terms of mortality, we assume that in any given year, the mortality was more or less evenly distributed across the different age groups, and I'll talk about that limitation later. And second is that in terms of the new infections, we assume 2 things. One, the global targets, of course, talk about 20,000 new infections or less globally. We attributed them entirely to these 27 countries, so maybe a slight overestimate. But also, we, for simplicity, assume that this is primarily happening in the age 0 cohort. We know that, of course, transmission can occur in slightly later ages through breastfeeding. So with these, the net effect of these patterns leads to these three scenarios in terms of the population decline. So for these 27 countries specifically, starting at about 1.4 million children in 2015, that was the data we had at the time, declining down. And in the outer years, particularly in the time window when some of these newer formulations are projected to start becoming available, you start to see a wider separation between those three curves. And so by 2025, you have a range of as low as 350,000 odd children living with HIV and as high as 500,000 odd living with HIV. And the point here really is that the variance in terms of these scenarios just for the total number of children living with HIV is high enough that our traditional forecasting methodologies for ARVs specifically, which may start talking about a 10% market share in year 1, a 15% market share in year 2, doesn't really mean a lot over here because 70% market share in one scenario is basically 100% of market share in the other scenario. So it's sort of a cause for pause and reflection on how we approach the commercial considerations here. We can convert these age cohorts that we're tracking in the model into weight band distributions using standard references. And across all three scenarios, you see that there is a skewing in the outer years towards the heavier weight bands. Not surprising because the kids who are born today are getting older and getting heavier, and there are fewer younger kids replacing them. Most pronounced in the aggressive scenario, but even in the conservative scenario, you see that there's a slight skewing towards the higher weight bands. But remember that this is in the context of declining numbers. So the overall or the absolute number of children in the lower weight bands is going to be declining. And therefore the need for some of these formulations in terms of consumption is declining. So of course, as with anything, any analysis, there are limitations, and this one is no different. We have old data. I might be troubling Mary Mahi, I don't know if she's in the audience or not, for some updated numbers. But even if we get those updated numbers, they are estimates and provisional, and there are limitations to the accuracy there, but it is the best source of data we have at this point. And certainly the model does make a couple of simplifications in terms of new infections, attributing them only to the age 0 cohort. But what that probably does is really overestimates the younger age and lower weight bands in the outer years because we're attributing them all to one group and not spreading them out each year. And lastly, of course, the simplification of the mortality assumption. But we don't really have a great handle on that in terms of actually what's happening in country, and we felt we'd be chasing false precision with the number of assumptions we'd have to make about different ART coverage rates by age group, what regimens different age groups are on, what the durability of those regimens are, et cetera, et cetera. But nevertheless, with those limitations and caveats, just a few conclusions. First, simply that the overall number of children living with HIV is going to be declining, and we can debate the exact amount, but it's going to be declining as PMTCT efforts continue, and that this population will be skewing towards the higher weight bands in general. The scenarios, the variance between these scenarios that we present and other scenarios we could probably think of may be greater than the variance of typical forecasting where we talk about what might be the assumptions of ART coverage. Is it going to be 80% or 90%, second-line migration rates, or market share scenarios between molecules? And fundamentally, the demand for pediatric formulations for the lowest weight bands is something that's going to decline over time. And what this means is that we really need to carefully consider what the post-regulatory sustainability for some of these products might be. And if we believe that these products are needed, we might need some sort of innovative financing mechanism. And particularly as we talk about donors leaving, this market starts to shrink. It may not be able to sustain itself in sort of a traditional market approach as we do with the adult markets, and as perhaps the procurement starts to fragment further and may require some other kind of pooling. And just want to emphasize that these estimates are not meant to be definitive. I'm certainly not an epidemiologist, but the point of this is to provide a frame of reference for a lot of the discussions that are ongoing for the development of some of these new formulations, so that we can really think critically about what is really needed so that we're not simply getting the product to the finish line in terms of regulatory approval, but we're actually getting the drug in the hands of patients who actually need them. So just finally, some quick acknowledgements. Mary Mahi from UNAIDS for providing us the data that we started with. Several of my CHAI colleagues who provided some really robust discussions, helped refine the thinking here, and of course, our funders. Thank you.
Thank you very much, Vinay. Have a question No question? Thank you very much for your presentation. I give the floor to Yogan to continue.
Thanks very much, Shuri. So we move to the next presenter, who is Arun Dutta from Palladium in the US. And he's going to tell us about can differentiated care models solve the crisis in treatment financing, analysis of prospects of 38 high-burden countries in sub-Saharan Africa. Great. Go ahead, Chief.
Sure. Can you see the slide? Okay, great. Thank you, Chair. This study is a part of the JIS special supplement that was released at this conference, so you should be able to read the whole paper there. And one thing that I want to say at the beginning is differentiated care is not predicated on donor transition or donors leaving or looking at the exit, but it's because it's good for patients and good for the health systems. So that's our starting basis. One of the foundational studies that informed this work is actually done by some colleagues and myself, and it was published in 2015 in PLOS. And it looks at 97 countries, so a much larger set of countries than the 38 here. And it looked at facility-level antiretroviral treatment. And it tries to estimate the future funding gap for facility-level treatment looking at 2015 baseline funding. So this map is from that study. It's available on PLOS, PLOS Med. So what it suggests is that there is a significant gap going forward in high-burden countries. Most of these countries are low-middle income, upper-middle income, and lower-income countries. And this financing gap is significant because it includes facility-level staff, facility-level overhead, and of course all commodities that are included in delivering ART. So while we can look at this financing gap as an important rationale for differentiated care and why efficiency in health systems is a critical issue, a more sort of related but separate issue is just the sheer number of health workers required to deliver the scale-up that we want. And as just a number to throw out there, WHO is projecting a 15 million health worker shortage by 2030 to meet all the needs for SDG. So given that, at this conference, over the very many sessions that we've all attended on differentiated care, it's been repeated that as countries started to think about differentiated care models, specifically differentiated ART delivery, one of the things behind that was the issue of health workers and whether they would have enough health worker capacity at low level as well as hospital facilities to meet the demand. So yes, that's one of the explanatory variables or explanatory factors driving the implementation of differentiated care, but we know that the patient-centered model and the improvement in health outcomes is critical. So what aspects do we look at in our study? So we look at facility-level ART management, which is the use of health workers, use of facility space, waiting rooms, the OPD, the outpatient department, and any specific standalone clinics that do ART. But also, we add the element of community-level ART interventions, whether it's for ART distribution or ART management in terms of groups, peer-led or outreach worker-led, and we add that into the DCM mix. So what we know is that multi-month scripting is one part of the solution for differentiated ART delivery, and that's been discussed at this conference quite a lot. We got some new evidence. But there's also a more efficient use of laboratory monitoring. So what does that mean? It means not just the clinical tests like hematology and creatinine, but also thinking about whether viral load and CD4 will be used in a more efficient way across different patient groups. So in order to do that, we set up our research question in a way that would focus on facility-level care and differentiated ART delivery. So our question basically states that if you look at these 38 countries here, and they cover most of the high-burden countries, except Ethiopia and Niger are two notable exclusions. What would be needed in terms of total facility-level resources with undifferentiated care versus differentiated care? And I'll explain a little bit more what we mean by differentiated care in our model. And what health workers would we need to support that scale-up? So we look at two stylized models. We know the differentiated care is starting to look more and more country-led, and there will be a lot of variation, but we created two stylized models based on the WHO guidance. And we use two criteria for one of those models: age, basically pediatric versus adults, and of course stability, the stability of the patient. And then four criteria where we add key population status, so the patient is a member of a key population group, and we also look at rural versus urban disaggregation. So we look at these costs, all of the costs you would expect, and we also looked at community-level intervention costs. So I'll just quickly walk through what those models look like, and I encourage you to look at our paper for a detailed description. So undifferentiated care. At this very moment, we know that there is no such thing as undifferentiated care, because each country is differentiating in some way, some form across the continuum of care. But in order to set up a counterfactual, we made these assumptions, and you can see that it assumes bi-monthly visits to do pharmacy. It also expects that pharmacy visits and clinical visits will more or less match. This is actually happening in many countries. And it does assume a fairly robust laboratory management schedule. It doesn't assume any community support at this stage. So if you look at the second model, we build it out much more. We disaggregate by age, so children will now start to get facility visits which they need based on whether they're new, they're stable or unstable. And then we also disaggregate by adolescents, where there's a slight difference from children, and then for adults above the age of 20. So in the two differentiated care models, the Model 2 and Model 3, we add community-level interventions for most of the cases, most of the patient groups. And the only interesting thing I would like to point out is that we made an assumption about urban versus rural. And we didn't find a lot of literature to support exactly what would be the difference in managing patients in an urban setting versus rural settings, but in discussion with key informants and experts, they suggested that in urban settings where the facilities are not as far, you would manage patients more intensively, perhaps at the facility, and need less community support because of that, because they could be seen more often. So these are some of the assumptions, and of course we can debate them, but the idea is to have wide enough ranges of assumptions, and the stylized models reflect enough of the reality to give us interesting results. So very quickly on methodology, it was quite a robust methods mix across different disciplines, epidemiology, economics, and also looking at health systems. So for the epidemiologic part, we use spectrum, which is this tried and tested method to project the number of people living with HIV and in different CD4 classes and looking at eligibility. And we use a 2016 spectrum file, so we have data updated up to the end of 2015. And we also use additional data to disaggregate populations by age, pretty similar to what Vineet did, but using the published data in the AIDS info database. And we also use country operating plans to look at specific data on stability, on loss to follow-up, et cetera, that factors into stability going forward. And we tried to build out the model. On unit costs, we used a variety of sources, mostly published sources, including our own work. We also used the global price reporting mechanism, which aggregates the price actually paid by countries for antiretrovirals across three ranges, low to high and a midpoint or median. And we use those estimates as well as forecasted price changes over time. So we are already factoring in some change to the price in antiretrovirals and laboratory diagnostics going forward, so we don't get confused by what might be happening in terms of changes to those commodities. And the last part is we did some analysis of full-time equivalent. So full-time equivalent is an idea of estimating the intensity of health worker time as expressed in what would be offered if they were to work full-time for, say, 260 days a year, 8 hours a day. So what would be an equivalent health worker? So we base these estimates on labor intensity from different studies that we've conducted and also literature review. So quickly, this is just for the 38 countries, because I know that there's a 19.5 million number that has been put out there for 2016. So this is close. I would say it's a little bit of an underestimate for the 38 countries because of the impressive increase we saw just in calendar year 2016. The largest increase ever in terms of the number of people initiating treatment in the history of the response. So our number for 2016 is a little bit of an underestimate, but this is pretty much in track with other projections. Just a little disaggregation for one of our years. So based on what we could gather in terms of stability information and using the definition of stability from the guideline, the WHO guideline, this is our best estimate of what stability would look like versus unstable patients in this particular year.
So yes, you can see that most patients, about the majority, would be stable, but there would be quite a few who, actually, sorry, I take that back. There would be quite a few who would be new, and then there would be a small minority that would be unstable. And the age disaggregation reflects the kind of trend that Vineet also brought out, that we are seeing a reduction in the pediatric cohorts over time due to various factors. And the key populations represent a fairly small proportion based on our modeling of the total number of people on treatment in these 38 countries. So what's our main result on cost? Our main result on cost is that if you implement DCM1, the first model which has age as well as stability as the main disaggregators, the main reason why differentiated ART delivery is happening, then you see about a 17.5, let's say 18% decrease in the cost of a facility level ART delivery, which is quite large and it's quite significant. And it's in line with some country-specific results that have come out at this conference, such as from Malawi, which suggested that multi-month scripting alone without diagnostic efficiency would generate about 10% in Malawi. So this is in line, but this is based on 38 countries and using specific data from each of those countries. Now, if you add two more factors for differentiation, the amount of total efficiency gain drops slightly, but is comparable, which is interesting because you're basically saying that now we're going to disaggregate between key populations and non-key populations, and for key populations, we're going to do more patient-centered care, have them visit the facilities, get more community-level support for them that might be needed. And that's actually not a big factor in terms of reducing efficiency, so it's a good rationale to add those two factors. The last point here is community-level interventions could go as high as $125 per person receiving them without reducing the efficiency gains to, $125 would be as high as you could go before the efficiency gains are completely eliminated. So that's much higher than the current estimates for what it would cost to manage a patient in the community, add support for stable patients. So the other interesting result is on full-time equivalents, and here you can see that basically reduced health worker time at the facility level would lead to about a 50% more or less reduction in the number of health workers needed across nurses, primary healthcare doctors, clinical officers who are important in care in many countries, as well as pharmacy staff who are involved in drug refills and pharmacy visits. So just a quick summary of our results. We, in our previous paper in 2015, estimated that just Eastern and Southern Africa would represent about 61% of total facility level financing gaps. So in these countries, of course, Eastern and Southern Africa are dominating the total costs. And once we use the median facility level financing gap, just the implementation of differentiated care models would reduce that gap by about 1/3, which is large. And in addition to more efficient sort of treatment sparing or dolutegravir treatment regimens implemented widely, that would be another 50% reduction in the financing gap based on our previous paper. So can differentiated care models lead to elimination of the treatment financing problem? Probably not by themselves, but they can make a huge contribution to these economies. So last point, and in terms of something to think about and maybe to discuss in our questions, one of the main issues that we encountered in doing the study is the so what. So yes, these efficiency gains exist. They are important on paper. Theoretically, when we look at large numbers of high-burden countries, these efficiency gains seem significant. But in order to actually capitalize on them, some real policy action, some real political will is needed. So let's quickly walk down through this. So multi-month scripting would reduce the number of patients visiting the facility, hence you wouldn't need as much facility space, you wouldn't need as much health worker time, and that could possibly be used for other health needs because we're in the SDG era. However, if your staff are only allocated to a site that is specific to ART, like a comprehensive care center, they cannot be reassigned that easily. So it needs a very specific decision by facility owners to realize these efficiency gains. Okay, one option is to just scale up the number of patients at the same site and hence reap those rewards. But how are we going to do that? Because one of the main themes of this conference as well as previous one is that we must decentralize care. So if you're decentralizing care down to the lowest level facilities, you cannot accumulate them back up to get these benefits. So I'll end with some other questions that I guess we don't have answers to, but would be important to consider. Thank you.
Thank you very much. You've eaten up into the question time, a fair amount, but we'll take one question.
Thank you. Jorge Saavedra, Healthcare Foundation, Mexico. One of your slides showed that your projections were that for this year, it will be 14.7 million people on ART. And that's, I assume, based on projections. Then the numbers of UNAIDS for 2017 are 19.5 million. And that's based on estimations, assumptions, country reports, and we know that country reports are government reports, sometimes better, sometimes not, but then you need to make assumptions in order to correct. So, but it's a 5 million difference, so that's a lot. 5 million on ART, more or less, is a lot. So, will you say, but I'm not expecting a politically correct answer, but a technical one. Do you think your projections failed, or the UNAIDS estimations are wrong?
Neither, because this is just the 38 countries, whereas UNAIDS projection is the whole world. So just for these 38 countries, we do expect that it's fairly close to the UNAIDS projection for 2017. But because the data was based on 2015 and used a sort of linear scale up to 1990 as a kind of a scenario, we're slightly below for these 38 countries because the scale up in 2016 was just that amazing. Slightly higher than what we had expected. But so I don't see any discrepancy.
So neither are correct or neither are wrong?
I don't know about UNAIDS. UNAIDS must have done a good job, but at least for us, we are only focusing on 38 countries, if I may reiterate, not the whole world. 19.5 is for the whole world. It includes India, it includes all of Latin America, all of the OECD.
Okay, thanks very much. And thank you very much for your presentation.
Thank you.
Thank you very much. Okay, let's move on. We're moving on to Heather Asfum, who is from the Population Services International in the US, and she's going to present on characterizing the South African private sector ART market. Heather?
Yes. Thanks for sticking around, everyone. I'm happy to be here, and I'm presenting on behalf of my co-authors, Kristen Little, Patrick Aylward, and Nina Hayson. And I don't have any conflicts of interest. Oops. Demand for HIV prevention, care, and treatment services continue to increase, putting an additional stress on an already overburdened public health sector. This graph from the UNAIDS GAP report from last year shows that public and private domestic sources are the only source of funding that have continued to increase over the last 5 to 10 years. At the same time, budgets from donors have flatlined or decreased, and there's been an increased demand for treatment due to the introduction of test and treat. PSI is interested in the private sector because of our experience in family planning and tuberculosis, where patients tend to show a preference for receiving services in the private sector. An analysis conducted in 2015, for example, showed that 30 to 40% of women using modern methods of contraceptive in 57 low-middle income countries received it in the private sector. Additionally, a 2011 study from 10 high-burden TB countries showed that 2/3 of incident cases of TB were treated in the private sector. We were interested in South Africa for several reasons. First, the South African private sector is well-structured, supported by a sophisticated evidence base and a commercial value chain. Secondly, private expenditure on healthcare in South Africa is pretty sizable, making up 52% of total health expenditure in 2014. And third, in terms of HIV, the number of people on ART increased 50% from 2.1 million in 2012 to 3.4 million in 2015, as you can see in this graph in the dark blue. Recently, the government of South Africa has started to leverage the private sector for their distribution networks for last-mile delivery. South Africa also spends the most on HIV than any other country, more than double the next country, Brazil. And the majority of its resources come from domestic public sources, making it especially important that the public and private sectors are well coordinated as the country begins to introduce its national health insurance. So we know that there's a private healthcare sector in South Africa, and at least until the middle of 2011, there were published figures of the number of people receiving treatment in the private sector. But it was a very open question to us what would happen as access to treatment in the public sector increased in South Africa. Would the private sector grow due to the introduction of universal test and treat? Or would patients leave the private sector in order to receive free treatment in the public sector? And what about patients who need second-line treatment? Might they be going to the private sector to receive those advanced services? We had several challenges in characterizing the size and scope of the private sector's role in HIV treatment in South Africa. First, there's a lack of standard definition of the private sector, with some definitions including NGO service provision. And second, it's been several years since there's been a published figure of patients receiving treatment in the private sector. The most recent figure is for mid-2011, and that doesn't capture the significant scale-up of treatment in the public sector. So in the absence of this data, we looked for a proxy and turned to procurement data that's available for South Africa. For the public sector, we exported data for South Africa from the Global Price Reporting Mechanism, or GPRM, a database of international transactions of HIV, TB, and other commodities purchased by low and middle-income countries. For the private sector, we use sales data from IMS Health that collects data from manufacturers, wholesalers, distributors, hospitals, and pharmacies. In South Africa, IMS Health accounts for 92% of total private sector pharmaceutical sales, with the 8% balance being a statistical projection. We use data from the calendar year 2012 through 2015 because those were the years that had complete data in both data sets. And to avoid double counting, we used any product including efavirenz or nevirapine and pediatric doses of lopinavir ritonavir as a proxy for first line, and for the second line, we use atazanavir and adult doses of lopinavir ritonavir. In the data sets, the only comparable units were in GPRM and IMS Health were total volumes of units procured. This posed a challenge because 50 billion pills or milliliters of a product doesn't mean much when you're looking to estimate the number of people who are being served. In addition, during this time period, the number of the uptake of fixed dose combinations was increasing rapidly, which would naturally decrease the number of volumes. Therefore, we had to figure out a way to make interpretation of this data more user-friendly and account for the decreased volumes due to the uptake of FDC. There were a couple of ways we could have gone about collecting this. We came up with the term patient years of treatment as a proxy for service delivery, and that's basically asking how many patients could have been served with the volumes of ARVs that were procured. We calculated this by dividing the total number of units by the number of units you need to treat a patient for 1 year. So, for example, if there was a procurement of 36,500 pills and a patient takes 1 pill per day, then that procurement was equal to 100 patient years of treatment. We then analyzed our data in Excel using pivot tables. So on to the results. To start with, we wanted to get an idea of just how big the private sector market is in South Africa. To get a rough sense, we compared the total number of patient years of treatment for first and second line regimens in the private sector to the number of people on treatment in other low and middle income countries in 2015, according to UNAIDS. It's a little apples to oranges, but we felt it was sufficiently comparable. And while the South Africa private sector looks small in comparison to their huge public sector treatment program, it's still significant on a global scale, making up enough treatment to be the 14th largest treatment program in the world and the 10th largest program in Africa, larger than Rwanda and Swaziland, and slightly smaller than Thailand and Botswana. We then looked at the patient years of treatment for first and second line regimens separately. And when we first looked at the data for the first line regimens in the private sector, it didn't seem all that notable because the number fluctuated from year to year, with it peaking in 2014. However, in comparison to the rapid growth in the public sector, we found it very interesting that the private sector procurement stayed relatively stable. Although the number of patient years of treatment wasn't growing during this period of time, neither was it substantially decreasing. And we think this is noteworthy as we think about the role that the public sector could and ought to play in the expansion of treatment. Next, we looked at a breakdown of regimens procured in the private and public sector in 2015. The chart on the left shows the private sector, and the chart on the right shows the public sector. As you can see, the big difference between the public and private sector is that almost a quarter of the public sector procurement is for efavirenz 200 milligrams, which is used for pediatric treatment, while that made up less than 1% of the procurement in the private sector. In addition, the private sector procured a wider variety of products than in the public sector. In the private sector, 7 products made up the 4% other that you can see in light gray on the chart on the left, and yes, shown on the chart on the left, while the public sector procured just 7 products total. However, the products that made up the majority of the procurement in this year were tenofovir, FTC, efavirenz as a fixed-dose combination. So it's evidence that they may be following the treatment guidelines in the private sector. Next, we looked at the total number of patient years of treatment for second line in the private sector. That increased year over year with changes between anywhere from 3 to 10%. This graph shows a breakdown of second-line patient years of treatment by product, either atazanavir in light blue or lopinavir-ritonavir in dark blue, and shows that adult formulations of lopinavir-ritonavir dominated the market, making up, on average, 83% of the patient years of treatment over the 4-year period. And again, what looks kind of modest on its own is interesting when compared to the public sector. The public sector patient years of treatment for second-line regimens varied pretty significantly from year to year. And in 2015, there were reports of stockouts of lopinavir-ritonavir due to insufficient manufacturing. Nevertheless, the private sector procured nearly 1/4 more patient years of treatment for second-line regimens than the public sector did in 2015. A few limitations on our data. First is that the GPRM and IMS health data may not be completely analogous, but as they both capture volumes of procurement, we believe that they are similar enough for at least an initial analysis. Secondly, a patient year of treatment is not equivalent to a person receiving treatment. This is because a patient year of treatment is looking at how many patients could be treated using a procurement, but it does not show how many people actually receive that treatment. But still, we think it serves as a useful proxy. And finally, some private sector providers might be providing treatment using public sector procurement or financing. And in this case, they would be counted in the public sector, not private sector, therefore slightly underestimating the private sector. So total procurement in the South African private sector is significant when looked at on a global scale. As we saw, patient years of treatment in the private sector were comparable to the number of people receiving ART and other low and middle income countries. This makes it especially important to better understand who is being served in the private sector. Second, our evidence indicates that patients continue to rely on the private sector for first and second line treatment, even as they become increasingly available in the public sector. In fact, this may be especially true for the second line, where where the private sector consistently procured more regimens than the public sector. It also appears that the private sector is mostly in line with the public sector guidelines. I know that there's been quite a bit of work to achieve this through the South African HIV Clinician Society, and the fact that the tenofovir FTC and efavirenz fixed dose combination is the majority of procurements in both the public and private sectors shows that this is working. And finally, our data suggests that there's almost no pediatric treatment in the private sector, with only 2% of the product procured being for pediatric doses. Going forward, there may be opportunities to leverage the domestic funding through the private sector as donor and domestic public sector budgets and facilities reach capacity. We believe that this analysis offers an opportunity for the government of South Africa to leverage patient willingness to pay, but we need to have a fuller understanding of the private sector itself and who's using it. And finally, we suggest conducting a landscaping of cost to patients in both the private and public sector. We tried to look at the difference in cost between the private and public sector, but it was unclear how much of the difference was due to the inclusion of warehousing and distribution costs in the private sector versus a markup for profit. Nevertheless, even if products cost more in the private sector, there may be patients for whom the opportunity cost of receiving treatment in the private sector makes paying those prices equal to the opportunity cost of free treatment in the public sector. Thank you very much for your attention, and I look forward to your questions.
Thanks very much, Heather. Any questions for Heather? I must say this has been illuminating for me personally, given that I work in South Africa. So, Heather, thank you very much for your presentation. There aren't any questions. Thank you very much, Heather.
Thank you.
So moving on to the final presentation, and this is by Ruan Barnabas of the University of Washington. She's going to speak on the cost effectiveness of routine viral load monitoring in low and middle income countries, a systematic review. Rowan?
Thank you very much, and thank you to the conference organizers for giving me this opportunity to speak. And if you are still in the room, thank you. You must be wondering, like me, is that costly viral load monitoring worth it? The WHO recommends HIV viral load monitoring for clinical impact, but the cost of a viral load test is substantial. Under what conditions are the health gains from viral load monitoring at a cost such that it is cost effective? And what can we learn from previous studies? The hypothesis for this analysis is to examine whether key features of program design and delivery costs drive the cost effectiveness of viral load monitoring. So just a one-slide primer on cost effectiveness. The health benefits from viral load monitoring should be greater than those foregone due to limited resources being unavailable for other priorities. And this requires comparing the cost per disability-adjusted life year averted from viral load monitoring with a cost effectiveness threshold. And I'll say a little bit more about that when I get to the results. But it's essentially the change in costs for a new program over the change in health gains. For this review, we conducted a systematic review of studies on the cost effectiveness of viral load monitoring in low and middle income countries. We did a broad search, including all terms for viral load and costs and economics in PubMed, Embase, and conference abstracts. And to be included in the study, studies had to have a cost effectiveness analysis for viral load monitoring and to be in a low and middle income country. We followed the Cochrane collaboration guidelines and the PRISMA reporting guidelines, and the results were synthesized qualitatively into themes. We reviewed over 1,165 unique abstracts. 23 were reviewed and 18 met the inclusion criteria. The studies were set in sub-Saharan Africa, Cameroon, Uganda, South Africa, Zambia, Zimbabwe, Cote d'Ivoire, Vietnam, and Thailand between 2001 and projected all the way forward to 2035. There were 2 randomized control trials and 16 modeling analyses. Overall, 12 of the 18 studies concluded that viral load monitoring is cost-effective. However, both cost-effectiveness analyses from the RCTs did not find viral load monitoring to be cost-effective. And the results, the incremental cost-effectiveness ratio, so the change in costs over the change in health, varied widely from $68,084 per quality-adjusted life year gained to $326 per disability-adjusted life year averted. And the threshold to determine whether or not this is cost-effective depends on what alternative gains you could get for the same amount of money spent. There was really marked heterogeneity in our results due to variation in healthcare resources available and in the settings. And until recently, there was a lack of consensus on appropriate cost-effectiveness thresholds for a given setting. Within the analyses, there was a great cost in variation of viral load testing from $6 to $104 per test. There was variation in whether the cost was fully loaded. That's all the costs associated with getting a viral load result. The annual cost of ART also varied widely from $108 to $2,071 per client per year. And these massive differences in costs are due to different agreements with manufacturers, the volume of demand, advocacy, differences in human resource costs, and that did vary a lot between the studies, and then calendar time. And here I just want to highlight that both RCTs were conducted prior to the agreements that CHI have negotiated for ART costs. When studies did look at the same type of analysis, so that the same scenario, so in this example, a paper by Keebler, where 3 authors looked at annual viral load testing versus viral load testing every 36 months, the results continued to vary widely because of the different time horizons from $3,000 to $6,000 per DALY averted. And some models did not include the benefits of decreased transmission as a health benefit, and that is a limitation of those those studies. So due to the heterogeneity, we were not able to estimate as summary statistics, but we did qualitatively review the studies, and we found 3 main factors that make it more likely for viral load monitoring to be cost-effective in a given setting using the appropriate cost-effectiveness threshold. And these 3 factors are really the take-home message of this analysis. So use of effective but lower cost approaches made it cost-effective. Ensuring that the viral load results were acted upon made it cost-effective. And then where viral load suppression supported less intensive clinical care, differentiated care also made the analysis more likely to be cost-effective. And I'll just go through those now. So use of effective but lower cost approaches included in 2014, Roche set the ceiling price for viral load testing to $9.40, $20 fully loaded. The second point was that downstream costs are really important. So second-line ART, the costs of protease inhibitor-based regimens varied from $205 to $600 per patient per year. And then including these lower-cost viral load tests and ART tests, ART costs really changed the ICERs. So in a very nice analysis by Owatara and colleagues published in 2016, including the costs changed the ICER from just over $4,000 to less than $1,500 per year of life saved. The next important point is that you really need action associated with a viral load result, and all the models assume this, that once you get the viral load test, it has to go to the lab, it has to come back to the client, and the provider needs to make a decision whether or not to change to second-line therapy if that's needed. And without this action following the viral load test, there's no health benefit from conducting viral load monitoring. And when we looked at the models and the criteria for switching, we realized that actually we do need more evidence about the criteria for switching to second-line therapy, including whether and how many confirmatory viral load tests to be done, what the next steps are in terms of adherence counseling, and point-of-care viral load tests might help decrease the time from doing the test to taking action on the clinician's part. Many models assume either an immediate or a 3-month time frame for switching to second line. And just a word of caution here, because less than 5% of all HIV-positive people are on second-line therapy. And then the third take-home message from reading all these studies is that client-centered differentiated service delivery simplifies care for HIV-positive people, and we've heard at this meeting many of those strategies, including visit spacing, replacing CD4 count with viral load monitoring, community-based ART, multi-month refills, using dried blood spot specimens, and then using clinical care resources for more complex cases for people not suppressed on ART. And viral load testing is key for doing this because it gives us evidence that individuals are doing well and that programs are running smoothly. And so the costs saved from differentiated care programs can be used for viral load testing. And I want to just share a nice example from Andrew Phillips and colleagues where they compared CD4 monitoring, and that's the blue text, and here the incremental total costs on the y-axis and the DALYs averted on the x-axis. And so the blue dot with CD4 monitoring, you can see that's fewer DALYs averted at a higher cost compared to, in the pink text, viral load informed differentiated care at a higher rate of switching, so appropriately switching to second-line therapy, and that's more DALYs averted for a lower cost. So looking ahead, integrase inhibitors with their higher barrier to resistance and possibly decreases the clinical benefits of viral load testing. So that's a new analysis to be done. There might be alternative methods of monitoring, looking for TAF or TDF in urine, and so we would need to reassess cost effectiveness as new ART and models of care are rolled out. So just to wrap up, cost effectiveness of viral load monitoring is context dependent. Scaling up differentiated care services can produce cost savings which can be used to support viral load monitoring. And conducting viral load monitoring gives us confidence that both individual health is maintained and that the programs for differentiated care are successful. I'd like to end by thanking all the wonderful authors who responded to our many emails about from the systematic review, and my co-authors, Nicholas Tan, Paul Reville, and Andrew Phillips, and thank you for your attention.
Ron, thank you very much. We have time for one question, if there is one. Yes, sir. Please go ahead.
First, congratulations. Your presentation was very good. So that's why I didn't want you to leave without a question. So, so my question is, do you have like a way to compare the cost effectiveness of viral load depending on the types of countries, like lower income, lower middle income, upper middle income, if the countries belong to a free trade agreement or if they belong to the European Union, because they are still under the middle income status. So we can also say, okay, it's cost efficient if you are not on a free trade agreement or something like that. I mean, it's just numeric, which is great, and we can draw conclusions, but also on these kinds of other classifications.
You know, that's an excellent suggestion. We didn't think about stratifying the analysis that way, and we can certainly look at it. We didn't do it for this review.
Thank you very much, Shawan. So before I thank my co-chair and all the presenters, what are the take-home messages? The first is, donors, please don't leave anytime soon. The second is that even as donors contemplate moving, and of course we know that at some point they'll leave, we need to increase domestic financing and we need to improve efficiency, and we heard a number of examples of how we should do that. Role of differentiated models, how to ensure that we get pharma to decrease prices even as they increase the quality of the drugs and new drugs come on the market, including pediatric drugs. What is the role of the private sector, including in the context of universal health coverage in countries where there are still big private sector players? And of course, don't give up on viral load testing. It has many, many clinical and social and economic benefits. And with those few concluding remarks, join me in thanking all of the presenters and my co-chair. And finally, thank you for your perseverance and for staying this long. Thank you very much.